A 100 milliliter bag of milky white fluid hangs from an 4-pole in a rented mansion bedroom. The infusion pump glows green at 3:00 a.m. The patient lies motionless, alone, while a ceiling fan turns overhead and a telephone rings unanswered down the hall. The fluid is Propofol. In an operating room, it is a miracle of precision. The closest medicine has come to a biological off switch for consciousness. In a bedroom, it is a death sentence with no witnesses. This is the story of the drug they call the milk of amnesia. A story that moves from a British laboratory in 1973 to the most famous cardiac arrest of the 21st century and beyond, into the silent deaths of the very doctors who thought they understood it best. You are listening to The Deep Archive. We leave the surface now. The hatch seals. The water darkens around the vessel. Pressure builds against the hull. Below, in the submerged rooms where the evidence waits, we find a syringe, a pulse oximeter slowing, a hospital curtain drawn around a bed that should have held a waking patient, and a house on Carolwood Drive where the difference between sleep and anesthesia became a matter of 9 minutes. The archive opens on a white emulsion that erases everything: pain, memory, breath, except the question that no one asked: what happens when a drug works too well? The answer begins with a failure on a laboratory bench in Cheshire, England, and a veterinary surgeon who refused to throw the vial away. It begins, as so many discoveries do, not with a flash of insight, but with a failure sitting on a laboratory bench in a glass vial, the color of thin honey. The year is 1973. The place is a research facility in Cheshire, England, owned by ICI Pharmaceuticals, a company better known for dyes and plastics than for the chemistry of sleep. A small team of anesthetic researchers has been given a mandate: find a better intravenous hypnotic than the ones currently cutting patients open on operating tables across the world. The bar is not high. The existing drugs, thiopental, methohexidyl, althacin, work after a fashion, but they come with a ledger of debts. Thiopental accumulates in fat tissue and leaves patients groggy for hours. Althacin, the newest hope, is dissolved in a castor oil derivative called Cremophor-EL, and Cremophor-EL has a habit of waking the immune system into a blind, screaming rage. Severe anaphylactic reactions, flushing, bronchospasm, cardiovascular collapse. In some hospitals, althacin was withdrawn from shelves, not because it failed to induce unconsciousness, but because it killed patients before the surgeon could make the first incision. So the team at ICI begins screening. Thousands of phenolic compounds, molecules built around a benzene ring with a hydroxyl group attached, are synthesized, diluted, injected into laboratory animals, and observed. The work is slow, repetitive, and unglamorous. A researcher draws up a milky or oily solution, finds a vein in a rat's tail, depresses the plunger, and waits to see if the animal stops moving. Most of the candidates do nothing. Some cause seizures. A few produce a brief stupor followed by violent recovery. And one molecule, numbered ICI 35,868, with the chemical name 2,6-diisopropylphenol, produces something unusual: a smooth, rapid loss of consciousness followed by an equally rapid, clear-headed awakening, without the twitching or agitation that plagued the barbiturates. The team should have been elated. They were not. The problem was physical, not pharmacological. 2,6-diisopropylphenol at room temperature is not a liquid that flows. It is a thick, viscous oil. the consistency of cold motor oil, and it refuses to dissolve in water. The only way to inject it was to mix it with organic solvents, cremophor-el again, or polyethylene glycol, but those solvents carried the same allergic risks that had already condemned althecin. Worse, when the researchers tried to inject the pure oil, it caused hemolysis, destroying red blood cells on contact, and intense pain at the injection site. The molecule was elegant on the inside and impossible on the outside, so they discarded it. The vial went back to the shelf. The notebook entry was closed. That should have been the end of the story. But chemistry has a habit of returning to its discarded objects, and in 1977, a veterinary surgeon turned researcher named John B. Glen pulled the file. Glen was not a traditional pharmacologist. He had trained in animal medicine, worked in practice, and then moved into industrial research, a path that gave him a different instinct than the pure chemists around him. Where they saw an oily failure, he saw a molecule that deserved a second chance, not because it was perfect, but because it was almost perfect, and the only thing standing between it and the operating room was a problem of formulation, not pharmacology, not toxicity, formulation. Glen began experimenting with emulsions. The idea was simple in principle, maddeningly difficult in practice. Suspend the oil in water using a surfactant and a mechanical homogenizer, breaking the oil into microscopic droplets that could travel through a thin needle without causing pain or clotting. He tried dozens of combinations. Most failed. The emulsion separated. The droplets coalesced. The preparation turned rancid within hours. But slowly, through trial and error, he arrived at a formula that worked: soybean oil, egg lecithin, and glycerol mixed at high pressure until the oil droplets were less than half a micron in diameter. The result was a fluid, the color of whole milk, completely free of organic solvents, that could be injected intravenously without pain, without hemolysis, without the immune system's fury. The transformation was almost alchemical. The same molecule that had been rejected as too oily, too viscous, too dangerous to administer, now flowed through a 23-gauge needle like a quiet thought. When Glen injected it into laboratory animals, the effect was identical to the pure compound: rapid unconsciousness, complete immobility, and a return to wakefulness so fast and so clean that the animals were standing and eating within minutes. No nausea, no prolonged sedation, no accumulation. It was as if the drug had no memory of its own administration. The emulsion was the breakthrough, and the emulsion, in its quiet way, contained the seed of everything that would follow: the good and the dark. Because here is the paradox that the researchers did not discuss in their 1980 paper in the British Journal of Anesthesia. The paradox that no one could have predicted from a laboratory bench in Cheshire. The very feature that made Propofol usable, the lipid emulsion that carried the drug into the bloodstream without resistance, was the same feature that would, decades later, enable the drug to be drawn into syringes and infused continuously outside the operating room. The same milk-white fluid that allowed a controlled, precise anesthesia for a 2-hour surgery could also be loaded into a pump and left running in a bedroom, or a call room, or a bathroom, because the emulsion made the drug easy to handle, easy to redose. Easy to forget that behind the milky smoothness was a molecule that could turn off the brainstem's drive to breathe. The researchers were looking for safety. They found elegance. And elegance, in the history of pharmacology, is rarely the same thing as safety. It is often the more dangerous cousin, because elegance makes a drug seductive, and seduction replaces caution with confidence. By 1986, the drug, now named Propofol from propyl and phenol, a name that concealed its milky appearance entirely, had completed clinical trials in Europe. Anesthesiologists who used it reported the same thing again and again. The patient drifted off as if falling into a natural sleep, lay perfectly still, and woke up asking when the surgery would begin. There was no hangover, no confusion, no dream reported, or at least none remembered. The drug was so clean that some doctors began calling it the anesthetist's dream, a phrase that would later acquire a second, darker meaning. The bottle was small. The liquid was white. The infusion pump made a single, deliberate click when its settings were confirmed. And somewhere in a hospital corridor, long after midnight, a nurse or a doctor would draw up a syringe, not for a patient but for themselves, watching the milky fluid fill the barrel, listening to the silence of a ward where everyone else was asleep. They would find a vein. They would push the plunger, and for a few seconds they would feel nothing, and then they would feel nothing at all. But that story comes later. For now, the vial sits on the laboratory bench. The emulsion holds. The drop of milk falls into the glass of water, dispersing in a slow, white bloom that looks, for a moment, like a cloud forming in reverse. Then the infusion pump clicks, and the drug begins its journey into the body of the first human patient, who does not yet know that they are holding the leading edge of a revolution, or that revolutions, even the quiet ones, always leave a bill to be paid. The archive opens with a milky fluid and a question that no one asked. In 1977, what happens when a drug works too well, too cleanly, too easily? What happens when the only thing standing between consciousness and oblivion is a lipid droplet and a thumb on a plunger? The answer would take 30 years to arrive. But the seed was already there, floating in the emulsion, white and silent and perfectly, terribly elegant. The high-pitched tone of a pulse oximeter measures something that most of us never think about until it changes. A steady beep means the blood is carrying oxygen. A slowing beep means the interval between heartbeats is lengthening. A silence means the finger on the other end of the clip has stopped receiving instructions from the brain. In a darkened operating room at 2:47 a.m., the beep is the only sound that matters, and the anesthesiologist is the only person in the room who knows how close that beep is to flatlining. Propofol enters the body as a milky white fluid, but once it crosses the blood-brain barrier, it becomes something else entirely, a key that fits two locks at once. Most intravenous anesthetics before it were single-action drugs. Barbiturates like thiopental enhanced GABA-A receptors and stopped there. Ketamine blocked NMDA receptors and left a trail of hallucinations and dissociative chaos. Propofol does both. At lower concentrations, it binds to the GABA, a receptor at a site distinct from benzodiazepines or barbiturates, increasing the frequency of chloride channel opening and hyperpolarizing the neuron into stillness. At higher concentrations, it also inhibits the NMDA receptor, the same glutamate-activated channel that ketamine targets. The result is a hypnosis so smooth and so complete that the patient does not twitch, does not jerk, does not fight the ventilator. They simply cease to be present. That stillness is the drug's signature, but it is also its most misleading quality. Because here is what the stillness conceals. Propofol has no analgesic properties. None. Zero. The patient feels nothing only because they are not conscious to interpret the signals, but the signals themselves continue to travel. The surgical incision generates action potentials that race up the spinal cord, cross the thalamus, and arrive at the cortex, where no one is home to answer the door. One anesthesiologist, watching the monitors of a patient under pure propofol anesthesia, described the state as a living body with no one home. The heart beats. The lungs rise and fall. The pupils react to light. But the person who used to live inside that body has been temporarily evicted, and the eviction notice came in a white emulsion. The strange part is not that propofol works. The strange part is how quickly it stops working. The drug's pharmacokinetics are almost unsettlingly precise. After injection, propofol redistributes from the brain to peripheral tissues in 2 to 4 minutes. That is not the half-life of elimination. That is the half-life of waking up. A patient who receives a single bolus for a colonoscopy will open their eyes before the gastroenterologist has finished writing the procedure note. There is no hangover, no grogginess, no slow ascent through layers of confusion. One moment, the ceiling lights are blurring into a tunnel. The next moment, the recovery room nurse is asking if they want coffee. The brain clears propofol from its receptors with the efficiency of a janitor sweeping a corridor after a party that ended abruptly. That efficiency is the anesthetist's dream and the anesthetist's terror. Because the same precision that produces a clean wake-up also produces a clinical reality with no margin for error. Propofol's context-sensitive half-life, the time it takes for blood concentration to drop by 50% after an infusion of a given duration, remains remarkably short even after hours of continuous administration. After 8 hours of infusion, the half-life is still under 40 minutes. That means the drug does not accumulate in fat tissue the way thiopental does. It does not linger in the bloodstream for days. It leaves quickly, completely, and without apology. But there is no reversal agent, no naloxone for propofol, no flumazenil. Once the drug is in the body, the only way to bring the patient back is to wait for the liver to metabolize it and the kidneys to clear it. The liver does this by conjugation with glucuronic acid, producing water-soluble metabolites that are excreted in the urine. The process takes time. Not much time, measured in minutes, not hours, but in anesthesia, minutes are an eternity. If the drug suppresses the brainstem's respiratory drive, the anesthesiologist cannot give an antidote. They can only ventilate. They can only wait. They can only watch the pulse oximeter and hope that the next beep arrives on time. This is the paradox that every anesthesiologist carries into the operating room like a folded letter in a breast pocket. Propofol is the closest thing medicine has to a biological off switch for consciousness. But it must be administered continuously, because the patient will wake up the moment the infusion stops. So the anesthetist sits at the head of the table, one hand resting near the infusion pump, the other near the ventilator controls, holding the patient on the threshold between presence and absence, breath by breath, minute by minute. The drug does the work of erasing the self. The anesthetist does the work of keeping the self from erasing permanently. The high-pitched tone of the pulse oximeter slows, then steadies, then slows again. In the intensive care unit, the rhythm is different, but the vigilance is the same. A patient with traumatic brain injury or severe respiratory failure may be sedated with propofol for days, not hours. The drug allows the medical team to paralyze the patient, insert a breathing tube, and let the body heal without the brain fighting every intervention. But prolonged infusion reveals a truth that the clinical trials of the 1980s did not fully capture. Propofol is not a sleeping pill. It is not sedation in the way that benzodiazepines are sedation. It is a reversible coma, and a coma requires management. The infusion pump is programmed with a rate measured in micrograms per kilogram per minute. Too low, and the patient wakes up enough to pull at the endotracheal tube. Too high, and the blood pressure drops, the heart slows, and the margin between sleep and cardiac arrest narrows to a razor's edge. The anesthesiologist adjusts the rate by small increments, watching the monitors, listening to the ventilator cycle, reading the patient's body in a language that has no words. The patient, of course, cannot read anything. They are not there. And that is the strange kindness of propofol, as well as its strangest cruelty. The patient remembers nothing, not the incision, not the tube, not the fear. The drug produces a perfect amnesia, anterograde and retrograde, wiping clean the minutes before induction and the hours of surgery. When they wake, they ask when the operation will begin. They do not know that it is already over. They do not know that they spent 2 hours as a living body with no one home, that their nerves screamed pain into an empty cortex, that the anesthesiologist held their life in a syringe and a prayer. The ventilator cycles again, low murmur of air moving through corrugated tubing. The pulse oximeter beeps, steady for now, and the anesthesiologist leans back in the chair, not relaxing but pausing. The night shift has 6 more hours. The infusion pump holds enough propofol for 3. The pharmacy will send more before then. And somewhere in the building, another patient is being wheeled toward the operating room, and another syringe of the white emulsion is being drawn up, and another person is about to discover that the off switch does not come with an instruction manual. The switch itself is elegant. The hand that holds it is not. The smell hits you before the door opens, not the sterile tang of alcohol wipes or the faint chemical bite of chlorhexidine. This is something else, a sweet, oily rancidity, like vegetable oil left too long in a warm pan. It comes from a syringe that has been sitting on the ICU counter for 6 hours, still loaded with the milky white fluid that was meant to keep a sedated patient still. The syringe was drawn up at 9:00 p.m. for a patient who was supposed to be weaned off the infusion by midnight. But midnight came and went, and the patient was not ready, and the new syringe was prepared, and the old one stayed where it was. Now it is 3:00 a.m., and the emulsion has separated. The fat droplets have coalesced. Bacteria have begun to multiply in the soybean oil and egg lecithin that were supposed to be harmless carriers. In 1990, a hospital in Ohio noticed an unusual cluster of post-operative fevers. Patients who had undergone routine abdominal surgery were spiking temperatures of 40 degrees Celsius, their blood pressures dropping, their white blood cell counts climbing into the danger zone. The common factor was not the surgeon or the operating room or the batch of sutures. It was the propofol. Someone had drawn up the drug into syringes at the beginning of the shift and left them at room temperature for hours, using the same syringe for multiple patients over the course of the night. The lipid emulsion, the very innovation that had made propofol usable, had become a petri dish. Over the next 3 years, dozens of similar outbreaks were reported in hospitals across the United States and Europe. The culprit was always the same: propofol syringes that had been left standing for as little as 6 hours, long enough for environmental contaminants like Staphylococcus aureus or Candida albicans to bloom in the nutrient-rich emulsion. the FDA issued warning letters. Manufacturers added explicit instructions. Propofol must be drawn into a sterile syringe and administered within 6 hours of opening the vial. If the infusion is interrupted, the syringe must be discarded. But ICUs are chaotic places, and 6 hours is longer than a night shift, but shorter than a memory. The syringes stayed on counters. The fevers continued, and the drug that was supposed to bring control brought instead a quiet epidemic of sepsis. The strange part was that no one had predicted this. The clinical trials of the 1980s had focused on pharmacokinetics and pharmacodynamics, how the drug moved through the body, how it bound to receptors, how quickly patients woke up. The trials had not focused on what happened to the drug outside the body, on the counter, in the syringe, in the hours between preparation and administration. That gap between discovery and wisdom would prove wider than anyone imagined. In 1994, a different kind of report began appearing in the medical literature. Not outbreaks, deaths. But these deaths were not happening in hospital beds. They were happening in bathrooms, in call rooms, in the parked cars of hospital parking lots. The victims were anesthesiologists and ICU nurses. The cause of death was propofol. The pattern was almost identical in every case. A physician or nurse with access to the drug would draw up a syringe of the white emulsion, find a private place, and inject themselves intravenously. The dose did not need to be large. Propofol, at anesthetic concentrations, produces unconsciousness in less than 60 seconds. The user would lose consciousness before they could remove the needle from their arm. And then, without the protective reflexes of an awake person, without the ability to reposition their head, to gasp for air, to call for help, they would stop breathing. The respiratory depression was not a gradual fade. It was a switch flipped from ON to OFF. By the time anyone found them, the drug had already redistributed. The blood levels had already fallen, but the brainstem had been without oxygen for too long. The mortality rate for recreational propofol use was extraordinarily high, not because the drug was toxic in the way that opioids or cocaine are toxic, but because it offered no warning signs, no euphoria followed by nausea, no anxiety or paranoia, no second chance to reconsider. A person using heroin or benzodiazepines might feel the effects building, might have time to recognize that they had taken too much. Propofol offered no such courtesy. One moment the user was drawing back the plunger, watching the milky fluid fill the barrel. The next moment, they were gone. No warning, no memory, no opportunity to call for help. The medical establishment gave the phenomenon a clinical name, propofol abuse among anesthesia providers, but the name could not conceal the fact that the abusers were the very people who understood the drug best. They knew the dose, they knew the half-life, they knew that there was no reversal agent, and they injected anyway. The gap between discovery and wisdom had become a chasm, and the people falling into it were the ones who should have known where the edge was. But the darkest chapter of propofol's early years in intensive care was not sepsis, and it was not self-administration. It was a syndrome that no one had anticipated, because no one had tested propofol for what it would do to the body after days, not hours, of continuous infusion. In 1992, a team of intensivists in Australia published the first formal description of what they called propofol infusion syndrome. The patients were children with severe traumatic brain injury, sedated with high-dose propofol for prolonged periods. After 48 to 72 hours of infusion, the children began to develop a triad of catastrophic symptoms: metabolic acidosis so severe that the blood pH dropped below 7.2, rhabdomyolysis so extensive that muscle tissue dissolved into the bloodstream, and cardiac failure that did not respond to resuscitation. What children died. The autopsies showed fatty infiltration of the heart muscle and necrosis of skeletal muscle fibers. The mechanism, when researchers finally untangled it, was something no one had predicted during the decade of clinical trials. Propofol interferes with mitochondrial fatty acid oxidation. The mitochondria, the power plants of the cell, normally burn fatty acids to produce energy. Propofol inhibits an enzyme called electron transport chain complex 2, disrupting the cell's ability to convert fuel into ATP. In a short surgical procedure, this effect is negligible. The body tolerates a few hours of mitochondrial suppression without visible harm, but over days, the inhibition accumulates. Muscle cells begin to break down. The heart, which has the highest energy demand of any organ, begins to fail. The kidneys, overwhelmed by the breakdown products of muscle, shut down. The patient dies not of propofol overdose in the traditional sense, but of metabolic exhaustion. The FDA issued a black box warning in 2001, restricting high-dose, prolonged propofol infusion in pediatric ICU patients. But the syndrome was not limited to children. Adult cases followed. Critically ill patients with sepsis or status epilepticus, sedated with propofol for days, developed the same triad of acidosis, muscle breakdown, and cardiac collapse. The drug that had been celebrated for its safety margin in the operating room, where duration was measured in hours, had become lethal in the intensive care unit, where duration was measured in days. Here is the paradox that no one at ICI Pharmaceuticals could have seen in 1977. Safety is not a property of a molecule. Safety is a property of the relationship between a molecule and a context. Propofol is safe in a 60-minute hernia repair. Propofol is dangerous in a 60-hour ICU sedation. The drug does not change. The context changes. And the arrogance of medicine, the quiet assumption that a tool that works well for a short time will work equally well for a long time, is the gap between discovery and wisdom. It is a gap that has claimed more lives than any single overdose. The smell of the rancid emulsion lingers in the corridor. The syringe is still on the counter. The nurse who drew it up has gone home. The patient in the bed at the end of the hall is still sedated, still on the infusion pump, still teetering on the edge of propofol infusion syndrome. The ventilator cycles. The pulse oximeter beeps. The curtain around the bed is drawn not for privacy, but because the attending physician does not want the family to see the monitor numbers dropping. The gap between discovery and wisdom is not a failure of science. It is a failure of imagination. Science gave us the switch. Wisdom would have asked what happens when we leave it on. We are still waiting for the answer, but the bodies are already on the ledger. The telephone rang 3 times in the empty hallway before the answering machine picked up. No one heard it. The ceiling fan turned slowly overhead, pushing the warm June air in lazy circles across the bedroom. On a bedside table, and 4 pole held a 100-milliliter bag of milky white fluid, connected by a tube to a catheter in the leg of the man who lay motionless on the bed. The infusion pump had been programmed hours earlier, its digital display still glowing green in the pre-dawn darkness. The rate was set to 25 milliliters per hour, a dose appropriate for a 150-pound patient undergoing a colonoscopy. But no surgeon was scrubbing in. No anesthesiologist was monitoring vital signs. The patient was alone, asleep in a rented mansion in Los Angeles, and the physician who had started the infusion had left the room approximately 9 minutes ago. By 2006, Propofol had become the most widely used intravenous anesthetic in the world, with over 40 million doses administered annually. In operating rooms, it was the gold standard. In intensive care units, it was a tool for controlling the most difficult patients. But outside the hospital, the drug had acquired another name. On the street, in the tabloids, in the whispered conversations of the insomniac wealthy, it was called milk of amnesia, or simply milk. The name was casual, almost affectionate, as if the drug were a bedtime drink rather than a surgical anesthetic capable of stopping a human heart. The migration of Propofol from operating theater to celebrity bedroom had been facilitated by a small, shadowy subculture of concierge physicians, doctors who traveled to patients' homes, carried their own medical bags, and offered services that fell somewhere between legitimate medicine and dangerous indulgence. Among the most requested services was deep sleep. Patients with chronic insomnia, patients who had tried every pill and every therapy, patients who simply wanted to close their eyes and wake up hours later without the fog of benzodiazepines or the strange dreams of Ambien. These patients learned that there was a drug that could deliver unconsciousness on demand, with a wake-up so clean that they would feel as if they had merely blinked. What they did not understand, and what some of the concierge physicians chose not to explain, was that Propofol does not produce sleep. It produces a reversible coma. Sleep is a brain state with its own architecture, REM cycles, slow waves, dreaming, arousal thresholds. A sleeping person will turn over, pull up a blanket, swat at a mosquito. A person under Propofol anesthesia will not. They will not cough. They will not reposition their head if their airway begins to close. They will not wake up if they stop breathing. Sleep is a negotiation between the conscious and the unconscious. Propofol is a surrender without terms. The telephone rang again. No one answered. At 100 North Carolwood Drive, the bedroom was large and quiet. The ceiling fan was not the only thing moving. A bag of saline hung next to the Propofol, connected to the same 4-line, meant to keep the vein open and the patient hydrated. On a tray nearby, open vials of lorazepam, midazolam, and diazepam, benzodiazepines that enhance GABA-ergic inhibition just as Propofol does, but through a different binding site. The combination was pharmacological synergy of the most dangerous kind. Propofol alone, at the rate programmed into the pump, might have been survivable. The benzodiazepines alone might have produced deep sleep without respiratory arrest. But together, the drugs potentiated each other, turning a margin of safety into a margin of error measured in millimeters. The physician had administered these medications over the course of the night, responding to the patient's complaints of inability to sleep. The pattern was not unusual by the standards of this particular practice. The physician had been treating the patient for insomnia for several weeks, using Propofol as a last resort after other agents failed. What was unusual, what would later be called criminal negligence by the medical examiner, was the absence of monitoring. No pulse oximeter, no capnography, no nurse. No backup. Just a physician and a syringe and a patient who trusted that the man with the medical degree knew what he was doing. The paramedics were called at 12:21 p.m., not by the physician but by a member of the household staff who found the patient unresponsive. When the ambulance arrived, the engine idling in the driveway at dawn, though dawn had come and gone hours earlier, the paramedics found a scene that defied comprehension. The patient was in cardiac arrest. The 4-line was still running. The Propofol bag was nearly empty. And the physician, when questioned, could not explain why he had left the room, why he had not called 911 sooner, why he had waited to summon help. The forensic toxicology report, released weeks later, told a story of accumulation rather than a single catastrophic event. The blood contained propofol at a concentration consistent with anesthesia, not sedation. It also contained lorazepam, midazolam, and diazepam, each at therapeutic levels individually, but together producing a combined effect that overwhelmed the brainstem's respiratory centers. The medical examiner ruled the death a homicide, not murder. Homicide in the legal sense, death at the hands of another, not by intent, but by abandonment of the standard of care so complete that it met the definition of criminal negligence. The physician had acted as if propofol were a sleeping pill and the bedroom were a recovery room. They were not the same thing. They had never been the same thing. Here is the paradox that the house on Carolwood Drive made visible to the entire world. The property that made propofol desirable to the insomniac rich, the ability to achieve unconsciousness without the drugged hangover of sleeping pills, was exactly the property that made it fatal outside the operating room. A sleeping pill leaves the user groggy enough to remember to breathe. Propofol leaves the user so completely absent that the body forgets that breathing is necessary. Sleep is not a coma, and no one wakes themselves up to breathe when the anesthesia is still running. The very elegance of the drug, its clean onset, its clean offset, its absence of lingering effects, becomes a death sentence when the person administering it confuses the bedroom for the ICU. The telephone in the hallway eventually stopped ringing. The ceiling fan continued to turn, indifferent. The paramedics loaded the patient into the ambulance, but the cardiac monitor showed a rhythm that would not return. At the hospital, the emergency physicians worked for an hour, pushing epinephrine, shocking the chest, searching for any sign of electrical activity. There was none. The body had been without oxygen for too long. The brainstem, deprived of the drive to breathe, had simply stopped sending the signal. The milk of amnesia had done what it was designed to do. It had erased consciousness completely, perfectly, without pain and without memory. The tragedy was not that the drug worked. The tragedy was that someone thought it was acceptable to use it in a bedroom without monitors, without a backup plan, without understanding that the difference between sleep and anesthesia is the difference between a nap and a narrow escape from death. The discovery did not end the story. It made the story portable. Portable enough to fit in a physician's bag. Portable enough to travel to a mansion in Los Angeles. Portable enough to kill a man who only wanted to close his eyes for a few hours. The house on Carolwood Drive is still there. The bedroom has been redecorated. The 4-pole is gone. But the lesson remains, written in toxicology reports and court transcripts, and the quiet, persistent fact that propofol does not forgive mistakes. It does not need to. It simply continues to work precisely as designed, whether the patient is on an operating table or in a 4-poster bed. The switch does not know where it is. The hand that flips it is supposed to know. And when that hand fails, the archive records another entry, and the ceiling fan turns, and somewhere a telephone rings in an empty hallway. The soft click of a metal file drawer closing in an archive, then silence. than the distant hum of a hospital elevator moving between floors, carrying someone toward either waking or not waking, indistinguishable from the outside. In the months following June 2009, the public expected a crackdown. The death at 100 North Carolwood Drive had been broadcast across every screen, every newspaper, every waiting room television. The drug that had killed a celebrity, that had turned a bedroom into a morgue, surely would be locked away, scheduled, restricted, made as difficult to obtain as the opioids and stimulants that had already filled the schedules. The Drug Enforcement Administration convened meetings. The medical community braced for new rules. The vial of white emulsion sat in hospital pharmacies across the country, waiting to see if its time had passed. Then the decision came. The DEA declined to schedule Propofol as a controlled substance. To the public, it seemed inexplicable. To the medical establishment, it was a victory won by argument. The American Society of Anesthesiologists and other professional bodies had submitted reams of testimony. Propofol was the safest, most controllable, most versatile intravenous anesthetic in existence. Restricting it would not stop abuse. Abusers were already healthcare workers with legal access, but it would cripple operating rooms, delay surgeries, and force doctors back toward older, more dangerous drugs like thiopental and etomidate. The DEA listened. And instead of a schedule, the FDA mandated new labeling that read like a guardian angel written into law. Propofol must be administered only by persons trained in the administration of general anesthesia and not involved in the conduct of the surgical or diagnostic procedure. The language was precise. It meant that the person pushing the drug could not be the person cutting the patient. It meant that a dedicated anesthetist had to sit at the head of the table, watching, waiting, holding the switch. It meant that the bedroom infusions, the concierge treatments, the unsupervised syringes, those were now explicitly illegal, not because the drug was scheduled, but because the conditions of its use had been written into the label. A physician who gave Propofol without monitoring, without training, without backup, was no longer practicing bad medicine. They were violating federal labeling law. The archive records the decision as a compromise. Propofol remained in every hospital, every ambulatory surgical center, every endoscopy suite. But the label became a kind of contract. We will give you this tool, but you must use it as if life depends on every milliliter. Because it does. Between 2010 and 2020, at least 27 anesthesiologists in the United States died from self-administered Propofol. The number comes from a study published in the journal Anesthesia and Analgesia, and the authors put the word "at least" in italics. They were not being coy. They were acknowledging that Propofol leaves the body so completely that post-mortem detection is unreliable beyond 48 hours. If an anesthesiologist dies in their apartment on a Friday night and is found on Monday morning, the blood may show nothing. No Propofol, no metabolites. Just a body that stopped breathing for reasons that the toxicology report will list as undetermined. The real toll remains. Invisible, dissolved into cardiac arrests of unknown cause, into deaths signed out as myocardial infarction or respiratory failure with no explanation. 27 is the number we can count. The number we cannot count is written in the silences between shifts, in the call rooms where a syringe was found but never reported, in the obituaries of middle-aged physicians that mention sudden illness and request donations to a hospital fund. The archive does not know those names. Neither does the DEA. Neither does the FDA. The drug erases consciousness, and then it erases itself, and the bodies it leaves behind are clean as a wiped slate. Here is the deepest irony, and it is pharmacological rather than legal. Propofol remains the only intravenous anesthetic that produces no active metabolites, no cumulative toxicity, no organ damage from repeated use. A patient can receive Propofol for 100 surgeries over a lifetime, and the 100th dose will be cleared from the body as quickly and completely as the first. There is no cirrhosis, no neuropathy, no cardiomyopathy, no dementia. The drug does not stain the tissues it passes through. It does not leave a signature. It is, molecule for molecule, almost eerily clean. And yet that cleanliness has never been translated into wisdom, because the drug still offers what it always offered, a perfect, reversible death of the self, for which the only antidote is time. Time for the liver to conjugate the molecule. Time for the kidneys to clear it. Time for the brain to remember how to breathe, how to wake, how to be a person again. The antidote is not a drug, it is a clock. And when the clock runs out before the drug does, when the infusion continues past the point of no return, there is no second syringe to reverse the first. There is only the pulse oximeter slowing, and the ventilator cycling, and the anesthesiologist's hand reaching for nothing. The most dangerous drug in the Propofol story is not Propofol itself. It is the human assumption that mastery of a tool implies mastery of the judgment required to use it. The anesthesiologist who self-administers believes they know the dose. The concierge physician who treats insomnia believes they know the patient. The ICU nurse who leaves a syringe on the counter believes they will remember to come back. Each belief is a small room with a lock on the inside, and the key is made of a molecule that does not care what you believe. The archive closes not on a solution, but on a quiet recognition. Some substances are too elegant for their own good. Elegance invites intimacy. Intimacy erodes fear. And fear, in the history of pharmacology, is the only reliable chaperone. Without it, the milky white fluid becomes just a fluid. The switch becomes just a switch. And the hand that flips it forgets that on the other side of that click is a person who will not wake up unless someone trained, someone vigilant, someone afraid enough to do it right, is watching. The metal file drawer closes. The lock engages. The archive holds the documents, the clinical trials, the sepsis reports, the toxicology sheets, the court transcripts, the obituaries. They will not be reopened tonight. In the hospital across the street, the elevator hums between floors. A patient is being moved from the ICU to the surgical floor. They are sedated but not anesthetized, asleep but not comatose, alive but not awake. The nurse pushing the stretcher does not know the story of the molecule in the syringe taped to the four-pole. The patient will not remember any of this. The elevator doors open. The stretcher rolls out. The doors close again. Somewhere, in a room without windows, an infusion pump is being programmed. The milky white fluid flows through the tubing. The pulse oximeter beeps. The anesthesiologist watches the numbers, one hand resting near the ventilator controls, the other near nothing at all. The switch is about to be flipped, and the archive, having recorded everything it can, falls silent. The most dangerous drug in the Propofol story was never the molecule itself. It was the assumption that mastery of a tool means mastery of the judgment required to use it. Below, in the archive, we found a white emulsion that erases consciousness with terrifying elegance, and alongside it, a pulse oximeter slowing, an unlocked syringe on an ICU counter, a bedroom ceiling fan turning while a telephone rang unanswered. The gap between discovery and wisdom claimed operating rooms, intensive care units, and a house on Carolwood Drive. The bodies are on the ledger. The label now reads, "Only the trained and vigilant may hold the switch." The pressure on the hull begins to ease. The darkness thins above. Black water turns to gray, then to the first green of sunlight. The hatch opens, and cold sea air fills the vessel. We carried the evidence up with us, not to seek the substance, but to understand the shadow it left behind. If this kind of quiet descent into science and history is what you came for, you can subscribe to The Deep Archive. The metal file drawer is closed. The elevator hums between floors, indistinguishable from the outside. And somewhere, in a room without windows, an infusion pump is being programmed again. The switch does not know where it is. The hand that flips it is supposed to know.